So it's been an exciting year for myeloma and NASH. I say that every year. Every year is truly exciting. What's unique about this year, I would say probably the most practice-changing oral abstract in our world is actually not from active myeloma this time, it's from smoldering myeloma. So the AQUILA were presented by Dr. Demopoulos earlier this morning on Monday, and were just published in the New England Journal of Medicine. And in brief, that was a study of Daratumumab monotherapy versus active observation in patients with smoldering myeloma. We kind of retconned it and went back and looked at patients who have high-risk smoldering myeloma by 2220 by our modern criteria for how we consider high risk. And basically, they randomized those patients to either receive 3 years worth of daratumumab, subcutaneous daratumumab for 3 years versus observation. Unsurprisingly, they found that daratumumab lowers the risk of progression. That's pretty obvious, but the question is that worth it, right? Are you actually changing the natural history of the disease, or how long patients live, or how well they live? And indeed, they met that bar. They found that quality of life was better, or at least preserved, in the patients that got daratumumab first of all. They found that PFS2 was better. So even after starting frontline therapy for myeloma, the patients who got dara up front still did better. And most importantly, and this is the kind of holy grail of smoldering myeloma treatment, they found a survival benefit. So they found that instead of waiting until someone gets active myeloma and giving them 4 drugs then, or typically 3 drugs in that study, a triplet regimen, and transplant, and all of this stuff when they get myeloma, if you intercept them and give them daratumumab now for 3 years, fixed duration therapy, we actually see an overall survival benefit. Patients are living longer and living better. So I would argue that is very practice changing. Of course, daratumumab is not approved anywhere in the world for smoldering myeloma, but the company that makes it has already kind of submitted it for authorization. Once it's there, I will say absolutely will be practice changing. I will recommend this for all of my patients to kind of think about, probably as a default, if they have high-risk smoldering myeloma, again, because there's a mortality benefit. The one word of caution I would say is that this particular study, they did a good job of excluding patients with active myeloma. Prior studies of this same concept of intercepting a smoldering myeloma have really been hindered by that topic of, what if some of these patients had active myeloma and you were actually undertreating them by calling a smoldering? Here, everyone is required to get a PET CT or MRI or something along those lines to rule out active myeloma. So that would be a word of caution. So when daratumumab gets approved for high-risk smoldering myeloma, before you start it, stop. And make sure your patient does not have active myeloma. You need to do a PET CT scan, ideally a PET CT scan and a whole body MRI, to really be sure you're not missing that. Because if they have myeloma, they should be getting myeloma induction therapy like a quadruplet or Dara-RD or something along those lines. If they do not, though, daratumumab I think is very appropriate.